Good morning, everyone. I'm Mandy Ashley, the director of the Aurora Health Alliance. This is our shifted around time for the 2026 spring quarterly community meeting. As always, thanks to our affiliates who fund us and keep the work that we're doing at the Aurora Health Alliance focused on improving access to care going. All right, Joe.
Thanks, Mandy. Thanks, everyone, for being here. Again, I'm Joe Glaviano with the Aurora Health Alliance and wanted to introduce you to our panel today. Hillary Jorgenson with the Colorado Cross Disability Coalition, Kate Wallat with Colorado Center on Law and Policy, and Amanda Carlson with Colorado Consumer Health Initiative. So I'm going to stop sharing my screen and turn it over to Hillary.
Hi everyone. So I am happy to set the scene for my co-presenters. They have actually done a lot for this presentation and are going to be talking more about specific pieces of legislation. But our main focus as an organization this year, for those of us who are not familiar with us, we are a statewide advocacy organization for people with all different kinds of disabilities. That's the cross in our name. And we have about 7,000 members across the state. And we kind of look on everything under the umbrella of disability, from employment to Medicaid to everything in between. Our focus this session has been on Medicaid and specifically the state budget's cuts around Medicaid. I'm sure many of you are aware our state is facing an intense fiscal crisis that has kind of three causes. The first is the taxpayer bill of rights, which just creates a structural deficit. Um, the second is HR1, which passed at the very beginning of July. Colorado's tax system is, no, I should say was, because we're in the process of uncoupling some of it. But Colorado's tax system was really tied to the federal tax system. So the tax cuts that were enacted in HR1 um, basically created a giant hole in this fiscal year's budget. So the state's fiscal year runs from July 1st to June 30th. So it straddles 2 calendar years. So we are currently in the 25-26 fiscal year. So HR1 basically the day it was signed into law create another $1 billion hole in the state budget for the 25-26 fiscal year. And as I'm sure you know, um, you know, um, we had to have a special session in order to deal with this. And sorry, I don't know that my video is clearly, but we had to have a special session to deal with this. The governor issued an executive order and then amended that executive order in October for further cuts. And then in the 26-27 fiscal year budget, we had, and we being the state, had a $1.5 billion hole to fill. So that's a lot of cuts. It's also important to know that K-12 education is 1/3 of the state budget. Medicaid, yes, that's billion with a B. Thank you, Katie. Not million. A million we could have filled. 1.5 million would have been great. Um, no, billion with a B. And so K-12 is one third of our state budget. Medicaid is another third. And then literally everything else is the final third. So we could literally cut 17 state agencies. We could literally cut like 12 of those agencies completely and like not equal the K through 12 and Medicaid portions of the budget. So just trying to help people understand like the dire situation that we are in and the really, really hard decisions that have had to be made. As many of you are probably aware, there have been extensive cuts to Medicaid. There's a 2% across the board provider cuts that is happening. There were extensive cuts made to long-term supports and services. Which I don't have time to run through all of them today, but CCEC has a webinar walking through all of the cuts that we did a few weeks ago that was recorded. And it's on our YouTube, but I'm also happy to send it to Mandy and Joe, and they can send it out to you as well. Because that webinar, it took us 90 minutes just to run through all of the cuts. But there's 2% across the board provider cut. There's soft caps in our home community-based services. There is going to be a soft cap on how many hours a caregiver can provide care for one client. Um, there's also cuts to Community Connector, which is a service that program that helps people who are on certain waivers spend time in the community. And there's also cuts to, illness medical equipment, um, lots of long-term skeleton services cuts off the bill. Like I said, I will send that webinar. They made cuts to non-emergency medical transportation. They also made cuts to cover Carolyn, which is a program that covers folks without proper documentation, and I think Amanda or Katie is going to talk more about that. But we are incredibly concerned about those cuts. The cuts in other parts of Medicaid are painful and are definitely going to impact people's everyday lives. But um, the CAC program sustained like 25% cuts. And so that's not insignificant for, a population and a community that really doesn't, like, literally has no other options. I mean, obviously, if you show up in an emergency room because of MTALA, you have to be seen. But we're pretty devastated by that particular set of cuts. And there has been a lot of work by advocates. The Senate is finishing up thoughts on the budget this morning. And so there has been efforts by advocates to try and lessen the blow of some of those cuts. So I am sorry to start this presentation out with gloom and doom. However, I think there are a couple of important things to know. The first is that both H1 and taxpayer bill of rights are human-made problems. And that means that humans made them and humans can make them better. And so my colleague Amanda is going to talk a little bit about a ballot initiative that we're working on later that would raise revenue for the states through the graduate income tax. But we are not going to be able to cut our way out of this situation. So, the H1 Medicaid cuts have not started in earnest. The pain that we were feeling from H1 was because of changes to the federal tax system that necessitated changes to our state tax system. And so the H1 Medicaid cuts have not started in earnest yet. Also, as long as the taxpayer bill of rights exists in its current form, we are going to have structural problems with our budgets. We are probably likely going to be having very similar conversations next year. If we do not take some action to try and raise some revenue. And so it is gloom and doom. Also, it's something that we can do about it, and Amanda's gonna talk about that. So, I'm happy to answer questions, at the end of this presentation, and I'll make sure that you get CCTC's materials so that, if you really want to watch the 2-hour webinar on long-term support and services cuts, you have that available to you. So, I think I am not sure if I'm turning it over to Katie or Amanda. I think Katie. But thanks for having me, and like I said, happy to answer any questions. And I put my email in the chat too. Our team is always available for long-term care, long-term support and services, Medicaid related questions.
Great. Hillary, thank you so much. I don't have a question, but I just want to thank you for the information. I think everyone here is aware of what's going on legislatively, budget-wise, but I think it's helpful to have specific examples because there were some that I hadn't even thought about, like the limit to caregiver hours and non-emergency medical transportation. Just, when you get to those details and you realize how impactful this is to our community members, our loved ones. It's just, it is more impactful. And then I love your statement of, this is a human-made problem and, humans can solve it. So I appreciate that. And I think we are turning it over to Katie. And so I will turn over to you, Katie. Thanks.
Thank you. All right. So yes, I am Katie Wallat. I am the legal director at the Colorado Center on Law and Policy. And I think when people hear our name, they think we're like a legal only organization and that we're all lawyers, and that's not the case. We are a statewide nonpartisan anti-poverty nonprofit. And so we focus on these 4 areas that you see here: food, income, housing, and health. But we really work to advance the rights of all Coloradans, and we envision a Colorado where everybody has what they need to succeed. And so you see in the corners are tools. So legal advocacy is one of the tools that we use, but it's one in kind of a whole toolbox of policy advocacy work that we do. We do research and policy analysis. So we publish reports and present data. We also do a lot of work in coalitions. I think I can probably speak for Hillary and Amanda when I say that we all kind of, like, none of us work alone. We all work together in the advocacy space and kind of work in coalition. And then we do a lot of legislative advocacy, which of course I'm going to focus on. So I'm not going to spend as much time on the budget as Hillary did, because she did such a great job of sort of giving the whole picture. But everything that we've been doing on the budget side of things is also alongside CCDC and CCHI in coalition. And so what we've really been doing is, signing letters to the JBC members earlier on in the process, drafting questions for them to ask, and worked on a lot of fact sheets. I think our main message is sort of like Hillary said, we have a budget problem. We don't have a Medicaid problem, right? Our budget problem is really caused by Tabor, because we actually have a small budget compared to other states because Tabor limits the amount of revenue that we can bring in. And in fact, Colorado actually underspends for many Medicaid populations. So I think in the press, sometimes it's reported that it's really the issue is Medicaid, the issue is Medicaid. And our message has kind of consistently been not exactly, right? This is a budget issue. And yes, Medicaid is a third of our budget, just like K-12. So yes, we're going to have to deal with it in that way. But the other piece that I think we focused on along with, again, CCDC and CCHI has been coverall. And coverall Coloradans, as Hillary mentioned, is for undocumented folks. It's also for the people that used to be able to get Medicaid, but are no longer able to get Medicaid because of HR1. So that includes refugees and asylees and victims of violence and that sort of thing. And so the idea here is to provide some health care for kids and for pregnant people that they can't otherwise get. There are cuts happening there, like Hillary said, and we'll kind of see what happens once the two chambers get together on that. But I'm going to focus mostly on specific pieces of legislation. So the first one is Senate Bill 138, which is called Reducing Administrative Burdens on Healthcare. And this bill is pretty long. It has lots of different provisions. They're focused on rulemaking, on hospital reporting, licensing of healthcare facilities, and health insurance carriers, which is why I put those three different agencies on the right there. But the biggest portion of the bill that we were focused on is hospital discounted care. We were among the coalition, again, including the other orgs here, to put it into law in 2021. And if you're not familiar with hospital discounted care, essentially it requires hospitals to screen all uninsured patients or anybody who asks for help in paying bills for Medicaid and for financial assistance. And patients who are at a certain income limit are eligible for what's called hospital discounted care, which basically limits the amount that these people can be billed for their hospital bills. And so in 138, there's language that touches on this about mostly focused on the use of a third party like Experian, like one of those companies to screen patients for hospital discounted care. And our position, we're in an amend position. And the reason we're in an amend position is because what we would like to see is, absolutely use those third parties like Experian, but you can't exclude people based on those results, right? So that the idea here is recognizing that sometimes the information that Experian is using or other third parties like Experian may not be correct. They may be using the wrong information. And so we don't want people to be screened out and say, oh, your income's too high for hospital discounted care. But we're happy to have hospitals use that screening tool to allow people to get hospital discounted care. And at this point, this bill hasn't even been in committee yet, and it's pretty late in the session, so it's still kind of in early stages. So we'll see what happens there. I tried to advance and it didn't work. How about that? Okay, there we go. And this one is House Bill 1235. And this is sort of a catch-all bill. That's why the bill title is just updates to Medicaid. It includes a bunch of provisions on things like NEMT, non-emergent medical transportation, outpatient therapy, HCBS providers, that's home and community-based service providers, and among other things. Our focus on this bill is on the HR1 and OBA implementation, the One Big Beautiful Bill, which I hate calling it that, but we'll just call it HR1. And so we worked with HCPF to make sure that language was added on the definition of non-qualified citizen or qualified non-citizen, the opposite of that, in a way that conformed with the federal law that was changed. And we also amended the bill, and I think it just got passed in seconds, to add requirements for data collection and sharing specifically about HR1. So, for example, how many people end up being terminated from Medicaid because they didn't meet the work requirements, right? How many people ended up being exempted, those kinds of things. And the goal here is that we all have data that really demonstrate what is the impact of HR1 and that we can use that in the future. So that, again, that language was added, so it's in the bill now. And so I think we're changing our position to supporting this bill, and we will see where it goes. Let's see. Okay, and then the last, there's two more bills I'm going to talk about. One is 1096, direct primary care. Again, both CCDC and CCHI were on the same page as with us. This bill, the direct primary care model, basically allows enrollees of Medicaid or anyone to pay out of pocket for primary care services from non-Medicaid providers. So we are very opposed to this idea. It has the effect of charging Medicaid enrollees for things they can get for free. All primary care is covered under Medicaid, and so it kind of encourages Medicaid members to pay for things that they really shouldn't have to pay for. Our research has also showed that these are typically pretty expensive. There's no family plan, so you have to pay per person, and often you pay in advance for care you may or may not receive. So this really would result in, some of Colorado's most vulnerable populations paying for care that they should be able to get and have the right to get, are entitled to get for no cost. It also means that people would miss out on care coordination or getting referrals to specialists. And more generally, and I think very impactfully, it really weakens the provider network, right? Because if you are a primary care provider, why would you join Medicaid? Why would you enroll in Medicaid to provide Medicaid services if you could just get direct money from patients? So we helped suggest some of the amendments that would have sort of done more consumer protection, would have required data collection to really understand the impact the bill would have on Medicaid enrollees and provider Medicaid enrollees and that sort of thing. Those amendments were not liked by the direct primary care providers, and as a result, they killed the bill. So we were successful in killing this bill this time around. We do think it will probably come back next year. I see Hillary nodding, so that's why I wanted to bring it up, because even though it's killed this year, next year's another year, another session, and we'll probably have to fight this fight again. Okay, and then the last bill I'm going to touch on is a bill that has not been introduced yet, but is a bill that has been in conversation for months and months, and it is a bill on county administration. So we're working with the governor's office, representatives from state agencies, including HCPF, CDHS, and CDEC, which is the Department of Early Childhood, and along with counties and their county representatives. And the idea here really is, there's several. We want to improve quality and standardization across the counties in the way that they administer public benefits, because we know that there's a lot of variance depending on where you live. So if you live in one county, you may be treated in a different way, or you may actually interact with different policies than at a different county. We're also, of course, as a state and as a nation in this place with HR 1 coming, where Colorado will receive less money from the federal government based on our error rates. And so those are the error rates both with Medicaid and the error rates with SNAP, having to do with that administration. And so we have to have all of our counties and the way that we administer these programs work really well with low error rates in order to continue to receive the funding that we get from the federal government. And as with anything and everything this session and in the future, we have to cut costs, right? We have to do cost containment because of our budget issue. And so this bill is very much in process. I've only recently even seen a draft like yesterday. So it's definitely going to be a late bill, but because it's, cross, executive is involved and the counties, the idea is that it should move quickly once we're there. I can't really say much more than that because, as I said, I've only just seen a draft, but this is definitely work that we've been really focused on and spending a lot of time doing, because we really want the provision of public benefits to be sort of the most efficient and effective that it can. And with that, I am going to turn it over to Amanda.
Thanks, Katie.
Hi, everyone. I'm Amanda Carlson. I am the Policy and Advocacy Manager at Colorado Consumer Health Initiative. If you're not familiar with us, as some of my colleagues mentioned, we work in coalition with a lot of groups to advocate for health equity and access in our state. So we've actually been around since 2000, intended to be a counterweight to a lot of powerful for-profit interests in the healthcare space by building cohesive consumer voice amongst health advocacy organizations and their constituents. We are a statewide nonpartisan nonprofit membership organization, so we have our member base that actually takes a vote to support or oppose or take positions on pieces of legislation that we engage with. Our goal is to work so all Coloradans have equitable access to high quality, affordable healthcare. There's a picture of our team. I'm not there because I'm fairly new. I started in January. But yeah, we have grown quite a bit over the years. I believe when the organization started in 2000, it was only a handful of folks, and now we have a larger, more comprehensive staff, which is great. So yeah, we have actually several areas, including policy work that we engage in. We do work at the Capitol and with regulatory agencies to work for change, um, and advocate directly on behalf of clients. We actually have a direct service arm called the Consumer Assistance Program. So we have a team of 5 that provide comprehensive free direct service to individuals to help them navigate health insurance, medical bills, and they also have a story collection and advocacy training arm as well. That's really important as we are able to have individual impact inform how we think about policy, move policy forward. And on the reverse side of that, having our consumer assistance program also helps us know if the policies we pass actually are working to improve the lives of Coloradans. We have an advocacy arm as well, doing community town halls, know your rights trainings, and other types of presentations. So yeah, as I mentioned, our direct service program has been around since I believe 2018. It is a free service that helps folks navigate billing claims and issues. We actually have had several clients that have had surprise medical bills to the tune of like close to $1 million that our team has helped navigate that down. And so they do really great work to ensure that folks are able to access care without the fear of crippling medical debt or things like that. So since 2018, we've helped 4,000 Coloradans save over 12 million in medical bills and prescription drug costs. We also have an advocacy arm, as I mentioned. Our folks on that team engage quite a bit with our policy work. We do a healthcare day of action where we bring constituents to the Capitol to talk to legislators, training them on lobbying and some of our priority issues and just really bridging that gap. We've definitely had folks say that they didn't know you could just go to the Capitol. So it's really important and we work in partnership with a lot of our other healthcare advocacy orgs to really bridge that gap between constituents and lawmakers. We do know your rights trainings, helping folks navigate the complicated insurance system from anything to this is what reinsurance and deductible and all of that means to what to do if you feel that you are being improperly billed or can't afford care, things like that. We do a lot of community events as well to educate on our policy priorities, ensure folks know that our consumer assistance program exists and is a resource, and a lot of storytelling as well to bring that personal consumer voice to how we engage in policy and just how we educate folks around some of the issues and barriers people can face accessing healthcare. We have engaged, as some of my colleagues mentioned, in a lot of different um, policies this session, but I narrowed down to 4 that we have been pretty heavily involved in. The first bill that we worked on is the Mergers and Acquisitions Accountability Bill, SB 41. Essentially, this bill, though it died in committee, would have provided the Attorney General's office oversight on large-scale acquisitions to ensure that vital resources are not reduced or cut. Unfortunately, we had an uphill battle with some of the lobbyists in Hospital Association who did not support this bill. And I will also pause there and note that we apply an equity framework in how we analyze policy. We examine root causes, assess community engagement, and really apply an equity lens on how this would be implemented and impact folks. So yeah, the next bill that was one of our priorities was House Bill 1267, Medical Debt Protections. This implemented some pretty baseline consumer protections regarding predatory debt collection practices. So just for some context, between 2022 and 2024, Colorado courts approved approximately 14,000 wage garnishments each year for unpaid medical bills. Many involved low-income patients or those who should have been covered by Medicaid. So what this bill would have done, again, faced sort of there's some complicated politics and dynamics at the legislature this year. So this bill did not make it out of a House committee. But we live to fight another day with both of these priorities as we feel that they are really important to improve health access and equity in our state. 1267 also prohibited creditors from extreme actions such as foreclosure or wage garnishment or bank account seizure. And it also implemented the right to affordable payments, where providers and debt collectors must offer reasonable payment plans capped at 4% of monthly household income. This one is, I think, really relevant to our work in the through our consumer assistance program. We engage with individuals who are facing pretty crippling medical debt quite frequently. So this was another piece of legislation where our direct service really was informed by, or excuse me, our policy work was really informed by what we're seeing through our direct service work. Whoops. Another bill we are working on in opposition is Senate Bill 140, which has moved through the Senate, and I believe will be up in seconds. My calendar in my brain of the legislative session is a little fuzzy right now. So Colorado, if you are unfamiliar with this context, is one of only a handful of states that has a prescription drug affordability board. It is it is made up of a lot of folks from the medical community who are intent on addressing skyrocketing prescription drug costs. So in October of 2025, last year, Colorado set the first in the nation upper payment limit on a drug called Enbrel, which by 2028 is projected to save Coloradans approximately $38 million a year. We are in opposition to Senate Bill 140, as it takes away PDAB's authority to review some of the most expensive prescription medications. It's actually part of a larger nationwide effort backed by pharmaceutical companies to fight some of these upper payment limits and reviews of drug costs to save consumers money. So this one is a complicated fight. There are a lot of folks in the rare disease community that support this bill. While we share the same sentiment that no matter what prescription someone needs, it should be available and accessible. We've just the policy as it's written provides a lot of exemption from the PDAB, which could end in really expensive, overpriced drugs for folks in a lot of different communities and prescription needs. And we are also yet to be introduced, which feels wild because we are this far. I think we have 27 days left in the session. We are working on legislation around the health insurance affordability enterprise. So essentially, this is a fee assessed on health insurers to fund measures that reduce consumer costs for health coverage plans. As Hillary mentioned, the harm from HR1 and also our restrictions with Tabor in Colorado, which I have a TED Talk about Tabor that I'll save you all from. But we are really limited in how we can utilize our budget and the money coming into the state to provide affordable healthcare for folks. With the federal level's failure to extend premium tax credits, a lot of folks are in a really challenging position of having to choose between paying other bills and accessing healthcare, getting their prescriptions. So the HIE, as we affectionately call it, adds a cost to insurer fees to fund programs such as OmniSalute, for example, which is a state-funded program that provides coverage for those who can't afford to purchase subsidized plans on the marketplace. A lot of folks that this program supports are those that make a little bit too much to qualify for Medicaid, but still are unable to afford a lot of plans on the marketplace. So I have also helped uplift everyone's spirits, I'm sure, with some of our legislative landscape. So there is something positive that you can actually get involved in. Wanted to end on a proactive note when things can feel a little bleak with our budget situation and just the state of the world. So our essential call to action is there's an opportunity to engage in a campaign that my colleagues, Hillary and Katie's organizations are also working on, as well, along with several other progressive organizations in the state. It's called Protect Colorado's Future campaign. It is a way to address some of the harms and restrictions our state faces with Tabor, and also subsequently with federal legislation from over the summer. This is a graduated income tax that we are collecting signatures to get on the ballot. We've been affectionately calling it the Tax the Rich ballot measure. So we need to collect signatures in 2% of all Senate districts across the state. So it's a big effort we have through the summer to collect these signatures in order to qualify for the ballot. Essentially, what this graduated income tax does is it actually provides a tax break for 97% of Coloradans. Currently, our tax system has a flat tax rate. So people of households of really high income are being taxed at the same rate as those who might be at a lower income and struggling to make ends meet. Where this graduated income tax starts to kick in is households that make $500,000 or more start to see a gradually increased tax rate. And then it progressively increases as you get into because there are these households, particularly in Aspen and across the state, as you get into the $2-3 million income range. So again, most folks would actually see a tax break, and this is projected to generate around $3 billion in revenue for our state. And as we are, as Hillary mentioned, facing a $1.5 billion shortfall and cutting really vital programs, we have some of the lowest paid teacher salaries in the nation. I've heard said before that Colorado is a wealthy state that operates like a poorer one. So this is a way to sort of mitigate some of the damage of our tax code, tax people a little more fairly, help folks out that are not making millions of dollars a year in income, and require that those who are wealthier in our state are paying their fair share to support really vital programs that we've talked about. So you can scan the QR code. I'm also happy to follow up with any information on the campaign. You can help donate to the campaign, volunteer to collect signatures, and the campaign folks will even come do a presentation to any space that you ask them to come to.
Yeah, they can even come to one of these meetings and present if you want a full presentation. Sorry,
Yeah.
Amanda, not.
No, that's a really, yeah, thank you, Hillary.
Put in that slide. If you want them to come present to you, put in that request as the come and present to whoever. And I also that we are presenting around the state. So if I mean I know you are just unaware, but if you are part of other organizations that have chapters or staff or whoever, in other parts of the state, if you want to hear from us, we will come to you. Yeah, we have an amazing statewide campaign infrastructure that I can take zero credit for, but the people who put it together did a great job, and so we're truly trying to be statewide. So
No, and it's yes, it is a huge statewide effort, and this I've heard some organizers say, we have the power of the people behind us, but we are fighting against a lot of the people that have a lot of money. So it will still be a challenging campaign, but really important, and we'll probably save Hillary a lot of 7 a.m. mornings being at the Capitol fighting for vital services not to be cut. So. With that, happy to answer any questions. And yeah, I would love for folks to engage with the work that we at CCHI and my colleagues do as well.
Great. Thank you so much. Thank you all. I wanted to just highlight just a few of the things in the chat, just for folks that maybe didn't see it or can't see it. There was a question, is there a requirement that a patient be screened for discounted care eligibility before being sent to collections? And thanks, Katie, for the answer. Yes, if they are uninsured or if they request a screening. So thank you for that. Bonnie put in that there's a rally scheduled on May 8th at noon at the Capitol for the medical debt collections limitations bill, which is House Bill 1267. So thanks, Bonnie, for that. Thank you again, Hillary and Katie and Amanda, so much for the work you do and for presenting today and for keeping tabs on this ever-evolving legislative session as always. It's a lot of work and we really appreciate it. Thank you all so much. We'll stick around for a few minutes, but hopefully you all have a great rest of your week and stay safe, stay healthy.
Thank you, everyone.
Thank you.
Thank you.